Hello and welcome everyone. What a pleasure it is to greet you all again. Okay, so our first topic for discussion today is key issues in treating children and young people with CML. And it's really a great pleasure to introduce our international expert, Dr. Maaike Luesink from the Princess Maxima Center for Pediatric Oncology in Utrecht in the Netherlands. Very much respected in the field, very much in demand. Maaike, welcome. It's such a privilege to have you here. Now, unfortunately, our scheduled regional pediatric CML specialist became unavailable at short notice. So we are truly honored and very grateful to have Dr. Oliver Henke for stepping in at the last minute and saving the day. Oliver worked at the Kilimanjaro Christian Medical Center in Moshi, Tanzania from 2016 to 2021. And although he's now back in Germany, where he heads the working group Global Oncology at the University Hospital Bonn, he maintains good and active connections with his colleagues in Tanzania and in sub-Saharan Africa. And as exemplified by him stepping in tonight, he's really a great friend of the International CML Foundation. So welcome, Oliver. Wonderful to have you here. So Oliver, would you like to share your slides with us, please? And as you're getting your slides up, I'll let the audience know how we're going to run this session. So Oliver might spend a couple of minutes identifying the key issues and challenges in treating pediatric CML in Tanzania. And then he will jump into presentation of his first case, which Maaike will respond to, and then we'll open up to you, the audience, for a couple of questions. He will then present a second case that was sent in to us for discussion. Maaike will respond, and then we'll open up to you, the audience, for a broader discussion about treating CML in children and in young people. So finally, just before Oliver takes over, I'll properly introduce the speakers for the next topic when we get to it, but I'd just like to acknowledge Dr. Amabene and Dr. Elisabetta Abruzzese, who are in the audience or will be there very soon, and welcome any contribution that they'd like to make to the pediatric CML discussion too. Okay, Oliver, it looks like you are ready to go.
Thank you very much, Aline and Nicola, and welcome to everyone listening to this talk today. Thank you for the invitation, and I'm happy to jump in. Unfortunately, I can't join for the whole session, but after this discussion and the case presentations about two cases that I brought, I will have to leave. But I'm happy to join and to support the ICML Foundation and our regional discussion group in Sub-Saharan Africa. As Aline said, I worked in Tanzania at Kilimanjaro Christian Medical Center, which is located in the northern part of the country until end of 2021. And I've seen also in our members that are present here, we have also Priscus Mapendo here, who is the head of the hematology laboratory from the Cancer Care Center at KCMC. And also I see Ahlam Nasser from the Muhimbili National Hospital in Dar es Salaam. And she is one of the lead researchers caring about CML in Tanzania. So there is a quite, well, probably small community, but a very active community in Tanzania looking at CML. If I think back with our experience we had with CML treatment in Tanzania, we started in 2018 partnering with Max Foundation. So from 2018 onwards, we were able to treat patients with imatinib. It really brought a massive change to our patients, because before this, what did we had at hand? Hydroxyurea probably, and we saw a study at the imatinib, the first imatinib study we had in average, I think the leukocyte count in average of the patients were 26,000, and in most of the sub-Saharan African cohorts, we see leukocytes count of 300,000, 350,000. So we look into late-stage presentations in CML cases as well, just as we know it from solid tumors in sub-Saharan Africa. So people come very late. And what does it mean if they come late? They might have acquired more mutations and probably TKI resistancy mutations. And that causes a problem in treatment response. While we saw that imatinib is very effective in the first month clinically, they all improve. They have, the spleen is going back. They have no splenomegaly. We see an almost normal blood count. But then after a couple of months, they tend to relapse, most of the patients. And then it's hard to get this into, back on track and back into remission. And this is also one of the case that I brought today. I have to say I'm not a pediatric oncologist, I'm an adult oncologist, but back then we didn't have any pediatric oncologists, so we had to care about the patients as well. Thanks to many donors and help, we have now a pediatric oncologist at KCMC, Dr. Esther, and she has overtaken these CML patients. But back then we had one case I would like to present from a 4-year-old boy who came from Tanzania, from the northern part, the Masai Mara area, and he presented with fatigue, shortness of breath, and excessive sweating to the pediatric department of KCMC in November 2018. And we were quite quickly involved because he had a white blood cell count of 499,000, an HB of 6.9. Platelets were normal, 189, but his spleen was massive. He was, as I said, he was 4 years old, so he was a quite small guy, but his spleen was 70 centimeters below the costal margins. We initiated a real-time PCR, and we saw it's positive with a ratio of 67%. So according to the other features he had, he was in chronic phase, and we managed him with initial cytoreductive treatment, gave him hydroxyurea, and then we started treatment on imatinib after enrolling him into the Max Foundation program. So we started according to his kilograms with 2 times 200 milligram, and then 1 week later, so 1 week later we started after initiating with hydroxyurea, 2 times 200 milligram, and then he showed clinically a very quick recovery. So his spleen, the splenomegaly was shrinking like massively, but we also saw, like after 1 month of starting of imatinib, we saw skin rashes, and I would call it an exfoliative dermatitis, and that occurred like 1 month after the TKA started, and that brought us to reduce the dosage. And you can see here, this is what we saw on his fingers and hand. This is the forearm, and then especially in the scrotum, we saw a lot of necrotic areas that all occurred with the TKI treatment. So we had to reduce the medication, and if I remember correctly, we also paused it for a couple of days, and we saw some improvement here. This was another month later, so we can see that this dermatitis got better, and also here on the forearm, that completely disappeared. With the scrotum, it was different. We had to refer him to the surgical department for debridement, because that was that gave us some big problems, and it was not healing well. We checked for his BCR-ABL after 3 months, and we saw a drop of 30 to 35%, which is, as you all know, this is far above our milestones that we should have. It should be below 10%. However, we were unsure at this point if this has to, is connected with an improper dosage, because we had to reduce the dosage due to the side effects. And we said because he was clinically stable and he was in a full remission hematology-wise, we said, let's continue. And then after 1 month, we checked again, and he was at 22%, which is absolutely above everything that should be the case. And then we basically decided to start second-line treatment with dasatinib. The problem is, in our setting, we had long waiting times. First of all, to be able to put him on the list for dasatinib, because dasatinib is one of the medications that is capped, so it's not unlimited for all patients. You have to put your patient on a list, on a waiting list, and then also you need to wait for the import process to be to go through all this process of importation, permission, and so on and so on. So we could start dasatinib in March 2020, 2 times 20 milligram. And then we lost the little guy for follow-up, because it was very challenging for him and his family to come to KCMC. His home was almost 560 kilometers away. He then presented, but he was on dasatinib, and we believe that he was also adhering to the therapy. But then in November 2020, he presented in a very bad clinical condition with blast crisis, and we saw in the flow cytometry 18% B-ALL cells. So we initiated induction therapy, but eventually this patient died. Yeah, this is the first case presentation, and I believe, Arlene, we're going to have now the discussion with Dr. Maaike, and then we come to the second case. Yeah, Dr. Maaike, welcome also from my side, and you have seen the case and seen, I guess, also the slides before. So can we just ask, like, I haven't seen this massive skin reaction in any other patient. So maybe a question, especially for children, how do we deal with these severe side effects in general? Should we go for dosage reduction first, or would you consider already in this point of time to change to second line?
Yeah, very impressive case, and the severity of the side effects is something we not frequently see this severe, so that makes it also quite difficult to give the right answer. With mild side effects, we generally give supportive care, like in nausea, give antiemetics, in skin rash, give steroids, or try to treat your side effect. But if it's so severe, you have no other choice than maybe to change your treatment. But the risk of the dose reduction is that you undertreat your CML in such an early phase, and then you will lose the child of a progressive disease. But it's also not very easy to change a medication in the setting in Africa. So I think it's really a difficult choice. What is the best choice in such a severe side effects? And also that all the TKIs have a little bit the same side effects. So you do not cannot predict whether switching to another TKI will not give the same side effects. But I think that dose reduction really gives a challenge of undertreating your CML. So it's a difficult dilemma, I think, and I'm not sure whether I can give you the right answer to this dilemma, but maybe people from the audience have suggestions, or you have any additional suggestions, or the other speakers?
Yeah, thank you. I think that when it comes to side effects, they are common ones, but every patient reacts differently. And I also haven't seen this kind of side effects. So I think it boils down to individual plan. And the fact that when it becomes too bad, you have to change. Thank you.
Absolutely. I mean, there's also the question about Dr. Maaike, would you, I mean, is imatinib still a first line for children? I would imagine in Europe we are looking into probably dasatinib as first line in children, or what is the normal approach?
Imatinib is still first-line treatment also in Europe, but you can also choose for dasatinib. That's freely available. And usually we do not start with nilotinib, but that's more due to the that you have to give it twice a day. And imatinib and dasatinib, we usually dose once a day. And we also include first-line treatment patients in clinical studies, such as the bosutinib study, or so we have many choices, but you can still, the biggest group is still first-line imatinib. And when they have signs of maybe retinal infiltration, so you want to give also something which penetrates your central nervous system, then we choose dasatinib frontline. But it's not yet the case that all patients skip the imatinib, and we see quite good responses on the imatinib. So many patients still start with imatinib.
Okay.
Anyone else have any questions on this first case, or is everyone happy for Dr. Oliver to move on to the second case? I know that Oliver's time is precious today.
Yes, I still have 2-3 questions on this case, or maybe these are also general questions. The growth impairment in children, because that was another thing that we saw in this, particularly in this 4-year-old, because we saw him more than 2 years, and he, of course, his growth was impaired under TKIs. What's your suggestion for that, or I don't know, how do you deal with this? Is there a way of pausing medication if they reach milestones, if you see there's a major molecular response, that you say, okay, now we give the growth a bit of more chance for a couple of months, or what's your approach there?
Yeah, the growth is a problem, although we do not see very frequently such young children, mostly teenagers, and then your growth is not that big of a problem anymore. Pausing your TKI, for growth, we never do that, but we now have with the bosutinib study, there are the first reports are that the growth is less inhibited by bosutinib. But on the other side, bosutinib gives a lot of diarrhea and nausea, which is also quite difficult. So maybe the new drugs can give less growth suppression. And for asciminib, I think we don't know yet what the impairment of growth is. And we are enthusiastic about the stop TKI studies, but for now, still the ideas are that you have to treat at least for 3 or 4 or maybe 5 years and have a deep molecular remission for a long period. So if you have a young child from the age of 4, then it will take you at least 5 years before you can stop your TKI. But I think the aim of trying to get good guidelines for stopping TKI in children is to prevent all these side effects also for your growth and development. And I think we need new drugs which impair the growth, not as much as these drugs we have now. So maybe bosutinib will be a good suggestion in young children, but that also has the side effects. And maybe in the future, we have more results on asciminib, and maybe that can be registered for pediatrics as well. But that will take years from now, I think. Yeah.
They're still ongoing, of course. Long-term studies are needed. And okay. Last question for that. We saw that all our, in adult patients, that our scores that we normally use, like the SOCA score, UTO score, ILTS score, is not really in line with what we see in the outcome in African patients. And we believe, we means our group in Tanzania, we believe that this is due to the late stage presentation and the accumulation of more genetic changes. Is there any scores for children? We don't know, we have never seen it, and I believe we have too few cases worldwide to have good scores.
Yeah, I think the ICML group of the from Europe and I'm sorry, did a lot of research on whether the scores for adults are also applicable to children, and I think these data show that it's not really applicable. And what you tell us about late-stage presentation also of chronic phase, I look back into my most recent 5 CML patients in the Netherlands, and they also presented with leukocyte counts between 300,000 and 700,000. So I think it's not an African problem, but it's in general the problem with pediatric CML, because patients only go to the doctor when they have a big spleen and a big belly, or they feel really bad, or they have a really low hemoglobin level due to your CML. And it's seldomly that they present with leukocytes of 50 or 100, because then I have one kid who came to me with a low leukocyte count, but he fell during biking and then went to the doctor and he drew blood and then he had a leukocytosis.
Okay.
So normally they also present quite late. And I think the CML group from the pediatrics also studied, is then the outcome also worse? But that is not really the case. That the high leukocyte count makes that the survival is poor, and the adult scores are not generally useful, and they are working on trying to make a pediatric score. And I think for pediatrics also the response to therapy is the best predictor. So if you have a good response in the first 3 to 6 months, that's a good predictor for outcome. But the nice scoring systems from adults are not really applicable to the children, and it's not necessarily that high leukocyte count or a big spleen are a poor prognostic factor in the children.
Mm-hmm. Okay, thank you very much. Okay, Aline, I move on to the second case.
Yes, if you're happy to do so, thank you.
Okay, thank you. Now the second case, let me see here. It's a bit older. It's a 10 years old boy. He presented with a progressive pallor, shortness of breath as well, and abdominal distension for about 3 months. And that was in December 2019. Again, very high leukocyte count, 340,000. His HB was 5.5. The platelets in this case was low, 37. Liver was enlarged, and the spleen as well. In this case, it was not a chronic phase, but it was already a blast crisis. We saw in the peripheral blood smear 75% blasts, and the FISH analysis was positive for BCR-ABL. So, yeah, the diagnosis clear is CML in blast crisis, and we started initial cytoreductive treatment, and then we added imatinib on it. Clinically, he stabilized quite rapidly, but at this time there was no second generation TKI available, at least not in a reasonable time frame. And of course, stem cell transplantation is not an option in this setting in Tanzania. So he was started on oral chemotherapy with palliative intent, and imatinib continued. So of course the patient, if I may, so it's terrible to say so, but I have to say, of course, the patient did not survive in this setting with an acute leukemia. And so I have some questions here for Dr. Maaike. What is the approach in Netherlands or Europe if you diagnose in a blast phase? What do you combine? What kind of medication or what kind of treatment approaches? And is that definitely in the very beginning that you would check for a kinase domain mutation at this point in time?
Yeah, for the blast phase, that's a difficult group, and it's our treatment strategy is induction chemotherapy, like you treat your acute leukemia as well, and it's usually a lymphatic leukemia. So then you have drugs which might also be available in Africa, I think, maybe vincristine, steroids, and then combine it with your TKI. We usually in the Netherlands are a little bit more aggressive, even also adding anthracyclines and asparaginase, but I can imagine that that's not all available in Africa. So you treat according to your lineage of your blast price with a intensive induction therapy, combining it with your TKI, but that can give additional toxicity. And usually we try to treat with chemo for 1 or 2 or 3 months combined with your TKI. And if you then reach a good remission, go to a stem cell transplant ASAP, because you can lose your remission as well. But if there's no donor available, you could also try to continue your TKI treatment. And usually we give a 2nd generation TKI, so dasatinib, because that has a little bit stronger and faster effect on your CML. And I think in adults, the treatment strategies are less intensive, probably also because adults are usually older and have more comorbidities. But in our center, the treatment of induction chemotherapy combined with TKI is really feasible and has a good response. And we recently published with the German group a nice paper on recommendations for CML blast crisis. So that is, I think, based on Western countries, but maybe people can learn from that how to do diagnostics and how to go with your therapy. And I think what we see also in the Netherlands, that the outcome in adults is quite poor with blast crisis, while we have quite good outcomes. So I think the intensity of treatment can help giving a better outcome. And we recommend, of course, also to do the kinase domain mutations. And I think in a recent study from also the German group, they showed that they are frequently present at diagnosis of blast crisis, but in our own hands, we never find TKD mutations. So I think you cannot, I think if imatinib is available, it's better to give imatinib than to give nothing. And I think there are not many data on the TKD mutations in CML blast crisis in pediatrics.
Okay, thank you very much. Yeah, and you see the uncertainty is maybe for everyone joining, the uncertainty is not only in the African setting, it's also in Europe, quite diverse, and it basically based on quite few cases, and but it's good to publish, and maybe this would be also a motivation for everyone from the African centers to publish your cases, your writing case reports of your children, because the more information that is available in publications, the better we can basically combine and merge all the information. So that is probably also one of the things and motivations. I probably think Dr. Maaike would agree, like to motivate all of you, if you have children with CML, to publish those cases. The last
what is really helpful in Europe is that we have an international registry. So all children can be registered in the database, and there we can then do studies, because we have maybe 3 or 5 new CMA patients in the Netherlands. So we can never do a study by ourselves. And because all the patients in Europe tend to be registered in the database with their leukocyte count, their response to therapy, their treatments, growth, all these kinds of things, that is really helpful. And it's not too difficult to register patients. Doing the studies about the results is, of course, a lot of work, but I think gives more data than only case reports. And maybe that is something which could be also interesting for the African countries, to try to make registries so that patients from different countries can be combined in one database for outcome data or difficult questions on therapy, growth. So that I would recommend to put effort into something like that.
Absolutely.
Teresa Lotodo, if I may just interrupt and encourage some of our audience to participate. Teresa Lotodo, would you like to take yourself off mute, or prefer that?
Yes.
Great, please go ahead, Teresa.
Thank you. I want to thank our presenters for the very Very, very good discussion. I just had a question because we've been talked about two platforms, the FISH and the RT-PCR platforms for the two cases, BCR-ABL testing. So which one is recommended, and like what's the frequency of doing the test in follow-up? That's my first question. And the second question, I wanted to ask if it is possible that this could have been ALL with BCR-ABL mutation. And so if there's a possibility, then how do you manage these patients? Thank you.
Regarding diagnostics, our diagnostics are mainly based and treatment response on PCR, but I think it's also what is available. The PCR gives a much higher sensitivity, so you can measure your treatment response much better. And we monitor it in the first year every 3 months, the PCR. And I think we continue on every 3 months afterwards, depending on the levels of your BCR-ABL PCR. And also, yeah, when you see a rise, then you have to increase the frequency, but that is probably difficult if someone lives 600 kilometers from the hospital. So I think the logistics are difficult. And we do not really frequently monitor the BCR-ABL. At least in the first year, we do it once every 3 months. And afterwards, we continue every 3 to 6 months, depending on the levels. So that was regarding the first question, but maybe Dr. Henke also has something to say about this.
Maybe just one comment, and this is just from personal experience in Tanzania, but not as meant as an evidence-based recommendation. I think in this setting where you have patients with such a high amount of leukocyte, you would probably not expect a good outcome after 3 months, because you still have a lot of cells that you know, will always leads to not reaching the milestones. We once had a smaller cohort of 30 patients, and we did the early molecular response after 3 months, and it was only 9 out of 30 patients had a good molecular response. So I would recommend, as long as they have clinically a benefit from the medication, to do the first PCR after 6 months. But this is just also taking into consideration the costs of it, because at least it's if you do it in private labs, it's around $120. If you have the cartridges and you use the Gene Expert machine, it's a minimum of $50, and this is quite a lot for patients. So I would recommend to do the first PCR after 6 months, if the patient is clinically stable and in full hematologic remission.
Thank you.
And your second question was regarding how to dissect the Philadelphia positive ALL from a lymphatic blast crisis in CML. That is a hot topic and a difficult question. And the review I previously referred to about recommendations for CML blast crisis also has some information on that. We have now turned into somewhat more fancy diagnostics to try to detect your BCR-ABL in subpopulations. But that is because we can do that. And so if you see your BCR-ABL also in your myeloid lineage, then it's probably a stem cell disease, so more a CML than a ALL. And in the most current classifications, they even now have the Philadelphia positive ALL with multilineage involvement. I don't know whether that is really a separate disease or that is just CML like ALL. And the therapy also for the ALL is intensive chemotherapy according to ALL protocol combined with a TKI. And for now we choose imatinib still as the TKI. according to our international treatment protocol. And it's not necessarily, if it's a Philadelphia positive ALL, you not necessarily have an indication for stem cell transplantation, but you have just a long treatment protocol of 2 years in Western countries with chemotherapy. But usually most of the therapy can be in an outpatient department, and you combine it with your TKI long term. So there are differences in treatment, and I think in the future we have to get more details on how to dissect the Philadelphia positive ALL better from the CML, and to see whether all CML blast crisis needs the stem cell transplant, because I think also probably patients who were treated as Philadelphia positive ALL maybe have a CML, but we don't recognize it, and they did not have a transplant. So maybe there is also room for a group which do not need a transplant, but that is still something under investigation. So blast crisis, you have to transplant. At least that is the idea, that's the best treatment. Philadelphia positive ALL, only transplantation if the response is not good. And a longer treatment with chemotherapy.
Oliver,
Thank you.
back to you, perhaps. I think you still have quite a few questions remaining.
I would just. Oh no, please. We have Simeon for
Simeon.
one question, and let me. I'm terribly sorry for that, but I have to leave now because my students are waiting online on the other side. But thank you so much for the opportunity. Thank you, Dr. Maaike, for joining and giving us your experience. And I hope to see you all on the next regional discussion. Thank you so much.
Thank you so much for hopping in, Oliver, and for someone who felt that you didn't have very much to say in the conversation. You've been fabulous. Thank you. We'll see you soon.
Okay. Bye-bye. Thank you.
Simeon, please bring your question to Maaike.
Okay. Thank you so much. Good morning, and thank you for that presentation. So I dropped part of one of my questions earlier, and it's concerning the first case that was presented. This patient, a 4-year-old, had BCR-ABL done at 1 year, and looking at the initial BCR-ABL and the one that was done at 1 year, so the value dropped from 67% to 22%. Of course, the response is not good enough. We expect it to be less than 0.1 by 1 year, but it's obvious that the patient had some response. My concern is, could we have continued the first line, the imatinib that the patient was on at that point, rather than switch? Because I also want to confirm if this patient had tyrosine kinase domain mutation analysis done before the switch was done at that point. And again, this was also a patient who had some side effects to the medication from start, had dermatitis and all. Are we sure that the patient actually adhered to the medication strictly during the 1 year due to some of the side effects that the patient has had? Then concerning the side effects too, I would like to ask, because most of the side effects are limited to the skin and on pressure area, the scrotum and the hand. I want to know if the patient was actually mobile throughout that period to be certain that we are not also considering pressure sore of some sort, rather than the straightforward dermatitis from the medication, which has been said to be a rare side effect for that patient. So these are some of the questions that I would like to ask concerning, and the dosage too. From what I saw, like the patient had 400 milligram daily at 200 milligram BD, and for a 4-year-old, I was thinking the patient would have 260 milligram per meter square. Is that 400 milligram as calculated based on the body surface area in order to avoid the patient being using, because all of these two could also result to some sort of side effects and adherence issues. So these are some of the clarifications I would want to seek. Thank you.
Maaike.
Yeah, thank you for your questions about the case. I do not know about whether the patients took the medicine correctly. I think dosage is important. I think Dr. Henke told that they based it on the weight, and we usually dose on the square meters with around maximum dose of 340 milligram per square meters. So I'm not sure what was the dose per square meter in this patient. We usually, if at 12 months the BCR-ABL levels are this high, we think that it's a treatment failure. And in treatment failure, you can do several things to determine what is the reason of treatment failure. If you are doubting that the patient take medicine, we are able to measure the imatinib levels in the blood, but I'm not sure whether that's also available in Africa. And I have some patients who did not respond really fast to the imatinib, and they also had low blood levels of the imatinib while taking their medicine correctly. And then we increased the dose even, but they didn't have any toxicity. And the other thing is that you can look for the TKD mutations if a patient is not responding good to your imatinib. But as said before, we seldomly see in our hospital TKD mutations, although it is reported internationally that it can happen. And so I think these were a few answers to your questions, and I do not have the details about this specific patient because I was not the treating physician.
Thank you so much, Maaike, and thank you, Oliver. Unbelievably, that is our time up, I'm afraid, for the pediatric CML topic. So thanks so much, Dr. Maaike Luesink and Dr. Oliver Henke. Some fantastic questions there and great answers. I wish we had longer.